Good afternoon, everyone. Welcome to another PINE session. PINE stands for Pulmonary Infections Network of Experts. It's an early career working group initiative of the PITB Assembly at ATS. During these sessions, we present an interesting case, go over recently published relevant literature, and get our experts to weigh in on the real-world implications of the same. My name is Divya Reddy. I'm an associate professor of medicine at Albert Einstein in New York. Our speaker today is Dr. Ryan Fitter, who's an excellent third-year pulmonary and critical care fellow in our division at Einstein. I'm delighted to introduce our expert panelists. We have Dr. Neil Schluter of Medicine and the Dean of New York Medical College. We also have Dr. Jane Carter, who's a professor of medicine at Brown University. She's president of the International Union of TB and Lung Disease. The goal of this conference is audience poll questions. Please feel free to type in questions in the chat, and I will try my best to get them answered. Without further ado, I'm going to let Ryan walk us through this fascinating case.
So good afternoon, everyone. It's an absolute pleasure to be presenting to you today. This is a really interesting case that we had the pleasure of taking care of in our hospital, and I'm going to go through all the different details and all the unexpected twists that went along with it. So this gentleman was a 39-year-old male. He presented to our emergency department with tinnitus, hearing loss, and ear fullness for 3 days. Other relevant details: he'd been seen at another hospital recently for 4 weeks prior for pneumonia. He endorsed long-standing productive cough, several months of malaise, functional decline, 6 months of weight loss, and decreased food intake. In terms of other really relevant details, he didn't have any known past medical history when we met him. Wasn't super engaged with the healthcare system, but as far as we were aware, had no other medical conditions. Didn't take any medications. He was born in California, but interestingly, he lived in Sudan for 21 years and had returned to the United States 11 years prior to presentation. He worked as a patient care associate in another hospital, so he had healthcare exposures. He had quit working 2 months prior due to feeling ill and fatigued. He reported having an abnormal skin PPD test in the past, and he also lived in a homeless shelter and had several roommates with cough. He reported daily marijuana use. He was an active smoker, and he had also an alcohol use disorder, and he was sexually active with multiple female partners in the prior 12 months. In terms of his vitals from when he first presented, his blood pressure was 99/57, and he was satting well on room air. He, however, was febrile to 102.9 degrees Fahrenheit, 39.4 degrees Celsius, and he was quite thin. His BMI was only 16.84. On our initial exam, the most relevant things were that he was thin and cachectic appearing. Because he had ear complaints when he came in, his ears were looked at, had non-erythematous tympanic membranes, and evidence of middle ear effusion. On his lung exam, he had right-sided crackles. In terms of initial labs, he was slightly anemic with a hemoglobin of 11. He was hyponatremic with a sodium of 128. Fluoride was 93. Did not have an AKI as far as we knew. The creatinine was 0.58. His transaminases are slightly elevated. His AST was 63. His ALT was 61. His albumin was slightly low at 3.0. His INR was slightly elevated at 1.3. In terms of other initial labs that were checked when he first got here, he was checked for COVID, was found to be positive, had a cycle threshold of 44. Procal was not elevated. He was checked for urine Legionella, which was negative. He was checked for strep pneumo urine antigen, which was negative. And he was checked for HIV, which was also negative. A quant gold, which came back several days later, was also sent off, and that was also negative. And this was his x-ray when he first came and when we saw him in the ER.
Dr. Schluger, Dr. Carter, do you want us to walk us through the findings on this x-ray?
Sure. Well, he's got multilobar pneumonia and with predominant infiltrates on the right, in the right upper lobe as well. And I think there's pretty obvious cavity formation on the right. Looks like there's volume loss. The fissure is pulled up on the right as well. So as I said, evidence of multilobar pneumonia, cavity formation, going along with what we already know about how much he weighs. You can see there's really a paucity of soft tissue. It's someone obviously who's quite thin. I realize the gun is loaded here, but in a person with several months of fever, cough, weight loss, and a chest radiograph like this, tuberculosis, even though he's got apparently at the moment acute COVID infection, tuberculosis would be the first 19 out of 20 things in the differential diagnosis of this X-ray, I think, in a young person.
It actually makes for an excellent segue into our first poll question, which is on the next slide.
So question number 1. What is the most likely diagnosis for this patient's presentation based on his history, his chest X-ray, and his laboratory abnormalities? Is it SARS-CoV-2 pneumonia, necrotizing bacterial pneumonia, invasive aspergillosis, histoplasmosis, pneumocystis pneumonia, tuberculosis, or necrotizing lung malignancy?
We're just going to give the audience 10 seconds to answer, and then we can review the results. What are your thoughts on the other, we're going to close the poll now, but what are your thoughts on the other options that we have in this question? He's a young guy with a multilobar pneumonia with cavitation. Do you think, what is the possibility of the other diagnosis? Because some of them have chronic symptoms as well.
Right. Well, I'd say, just to go down the list, SARS-CoV-2 pneumonia, patients with chest radiographs, first of all, patients with chest radiographs as abnormal as this one, who have SARS-CoV-2, are much sicker looking than he sounds. Right? He sounds, his O2 sat was okay. He appeared chronically, but not acutely ill, it sounds like. So I think to ascribe all of those radiographic findings to SARS-CoV-2 pneumonia would not be correct. Necrotizing bacterial pneumonia, again, the chest radiograph could be a radiograph of that, but the clinical presentation, again, seems more subacute than acute. Patients with necrotizing bacterial pneumonia usually quite sicker. And then you have things like invasive aspergillus pneumocystis would be possibilities if he were HIV positive or otherwise severely immunocompromised, which we already know. We already know at least he's not HIV infected. Histoplasmosis, with that much disease, again, I think you would expect to see in a more compromised host. And then necrotizing lung malignancy, that didn't seem to be a dominant mass. He's still relatively young to have lung cancer, not impossible. But the X-ray really is, to me, one more of pneumonia than a mass with necrosis. I don't know, Jane, want to?
Yep. I was going to also just point out that during the COVID-19 pandemic, it was not unheard of to present with your COVID and your contagious tuberculosis at the same time. So I think that doesn't bother me, that maybe he has both of those, and that the tuberculosis was what was much more chronic, and maybe now acute COVID is what tipped him over to finally bring him into the hospital. I would just like to point out that I saw on the initial labs that a quantiferon gold was ordered, and I'd just like to remind everyone that we need to think about what tests are used in different stages of TB. Quantiferon gold is really to look for TB infection, and so if you had the thought that you're thinking about screening for TB in someone who's acutely ill, that would not be my first test to think about the panel, although I know what everybody is doing is going down and clicking the blood tests that need to be done when someone first comes in.
I'm very glad that you said that. Actually, I agree 100%, and would almost go a little further to say that I don't think quantiferon gold is a test that should be ever ordered on a hospitalized patient.
Hey. I wasn't going to go that far, but okay.
You guys, this is important. This is something that we see in the hospitals all the time. It would be very educational for every just to why we should not be thinking about ordering quantiferon tests in the.
And I just want to, I agree also completely with Jane about the co-presentation of COVID and TB. I hope I didn't mislead anybody. The point I was just trying to make is that the X-ray alone, I don't think has been COVID.
Right.
Ryan, do you want to move ahead?
Yep, 100%. So our answer was tuberculosis. We completely agree with everything that our expert panels have said, which is why we thought this was the most likely diagnosis. And as often happens, he got a CAT scan. And it essentially showed what we expected based on that X-ray. Niels Brett is having fairly extensive disease, cavitation, especially in the right upper lobe, consolidation and train bud opacities, and just fairly extensive disease, highly concerning for tuberculosis. Which brings us to our next question. So based on what we know now with the CAT scan, what test would you do next to evaluate the imaging abnormalities seen in this patient? Would you get a bacterial sputum respiratory culture, expectorated sputum AFB smear, gen expert and culture, an induced sputum AFB smear, gen expert and culture? Would you do bronchoscopy with bronchoalveolar lavage, or would you initiate empiric treatment for tuberculosis?
There is a question in the chat from Dr. Vinod. In this chronically ill patient, would there be a need to do COVID testing at this point? And the question of a small pneumothorax on the left on the chest X-ray. Dr. Schluger answered the question.
I think in this day and age, any patient in the emergency room with a respiratory illness deserves a COVID test.
Should we review the results of the poll? So 74% said that expectorated sputum, AFB smear, gene expert, and culture. So Dr. Carter and Dr. Schluger, can you talk a little bit about the sensitivities of expectorated versus induced versus bronch with BAL? Because this is oftentimes something that comes up with pulmonologists when we are called for diagnosing patients like these, for evaluating patients like these.
Given the choices, I would have chosen B as well. Although, again, I'll go out on a limb here. I think AFB smear is a test that should be relegated to the history books and not done anywhere anymore. I think gene expert should be the first line test everywhere. But having said that, if a patient can produce expectorated sputum, that's a great sample, and there's no reason not to use it. If a patient can't produce expectorated sputum, there's a ton of data that sputum induction will almost always provide an adequate sample. And so if I had a patient who couldn't provide a spontaneous expectorated sputum, I would try to get induced sputum, and would certainly not do bronchoscopy in any patient before trying to obtain an induced sputum smear. There's plenty of data to show that BAL is no more sensitive than induced sputum for detection of AFB. Although most of that data, I think it's fair to say, is using AFB smear as the outcome. I'm not aware of too much data about using gene expert as the outcome. And I'd also say that I think, as everybody knows, the yield of AFB smear is anywhere from 50 to 70%, let's say, in patients with pulmonary TB, the sensitivity of AFB smear, whereas the sensitivity of gene expert nowadays, is really in the 85 to 90%, if not even a little higher than that. And so that's why I say that I don't think AFB smear should be done anymore for diagnosis of TB. We have a better test that's generally available. So only if you don't have access to gene expert.
So
Dr.
I
Carter,
agree.
would you like to add?
Oh, thank you. I agree with that approach. I just think the easiest thing is to walk in the room and hand the sputum cup to the patient and say, I'll be back in 5 minutes. And if a patient is coughing up sputum, I don't see why we don't do that. And then again, I think bronchoscopy is a lot of fun, and I always love to do it, but it does come with some small risk. So I always would do a sputum evaluation first. And then just to underscore Neil's point, WHO recommends a molecular diagnostic as the first test for everyone. I think that the smear is still important to me in terms of some of the public health responses. So I don't think of it as the diagnostic test anymore. I think of it as something that may help me to spur my contact investigations. So it's still nice to have for the public health department.
There's a question chat. In our practice in India, we have patients who come in with recurrent pulmonary TB, at times even within a couple of years of completion of treatment, in spite of good compliance and completion of treatment. In these patients, we believe that a positive smear AFB is suggestive of an active infection, whereas a gene expert could also show dead bacilli up to 2 years post the initial treatment. Hence, we do smear and nucleic acid amplification testing. Would this be correct?
Yes, you can't use, the gene expert can stay positive for up to 5 years that we know, and their results, their reports of even longer. So in these high burden areas where you're looking for recurrent TB, you need to opt back to smear, and I would always say culture, because you're going to need the susceptibility tests as well.
Thank you. Ryan, do you want to move forward?
And we completely agreed. We got expectorated sputum AFB smear, gene expert and culture on our gentleman. So as often happens when someone first presents to the hospital, multiple interventions happen at once before the diagnosis was quickly made. He was started on Paxlovid for SARS-CoV-2. He also was empirically given piperacillin and tazobactam and vancomycin. A full viral pathogen panel was checked, and he was found to actually be COVID negative on that, but his rhinovirus was positive. His blood cultures were sent initially and ultimately stayed negative, as were bacterial sputum cultures. A sputum AFB smear with gene expert was checked, and it was found to have 4+ acid-fast bacilli. The gene expert was MTB positive, along with rifampin resistance negative. Which brings us to question 3. What therapy would you initiate to treat this patient? Would you use rifampin, isoniazid, pyrazinamide, ethambutol daily for 2 months, followed by daily INH and rifampin for 4 months? Would you use the rifampin, INH, pyrazinamide, ethambutol regimen for 2 months, followed by 7 months of INH and rifampin? Would you use rifapentin, INH, pyrazinamide, or moxifloxacin for 2 months, followed by rifapentin, moxifloxacin, INH for 2 months? Would you use bedaquiline, linezolid, INH, pyrazinamide, ethambutol for 2 months?
We're going to give the audience a few seconds to answer that question. All right, can we see the result, Diana? So 68% voted for the 6-month RIPE regimen, 26% voted for 9 months of RIPE therapy, and 5% voted for the short course 4-drug regimen. Dr. Carter, Dr. Schluger, what are your thoughts about these regimens, and what would have been your pick?
So I'll say, so as far as we can tell, the patient has drug-susceptible TB, at least has susceptibility to rifampin. And so we would assume that the patient has drug-susceptible TB, although I'll point out INH resistance is quite common around the world. At least 10% of TB isolates in most places are resistant to isoniazid, but we'll leave that aside for a moment. So I think we would assume the patient has drug-susceptible TB. So regimen A, the 6-month short course regimen for drug-susceptible TB, is the most widely used regimen, and will cure most people and has a relapse rate sort of in the 5 to 7% range. On the other hand, I think we can identify patients who are at high risk for relapse based on some clinical characteristics. And this patient has some of those. He's got extensive bilateral cavitary tuberculosis. He's also quite thin, and I'm guessing certainly below 90% of ideal body weight. And those are two significant risk factors for failure or early relapse of the 6-month regimen. We published a paper in the TB Trials Consortium a long, long time ago, probably 20 years ago, where we identified 3 factors that predict early relapse after 6 months of therapy. One was extensive bilateral cavitary disease, which this patient has. A second one was initial weight less than 90% of ideal body weight, which I'm sure this patient has. And the third one was persistence of positive cultures at 2 months. We obviously don't know that about this patient yet. So in a sense, I don't think you really have to choose yet between A and B, but because we're just starting therapy, you'll have to see what happens. But I think B involves a little bit of guessing that this patient's going to be a little slow to respond. But I think you have to consider prolonging therapy to 9 months in someone like this. As I said, you're not going to make that decision for several more months. Regimen C was a regimen that we studied in the Tuberculosis Trials Consortium. It was based on 2 phase 2 trials that suggested that rifapentine, which is rifamycin, has exactly the same mechanism of action as rifampin. That is to say, it binds to RPOB gene and prevents RNA polymerization, but is more potent in terms of MIC and has a much longer serum half-life. We did 2 phase 2 studies that suggested rifapentine would be an extremely powerful substitute for rifampin in this regimen and could allow treatment shortening. The phase 3 trial did show that when rifapentine was substituted for rifampin and when moxifloxacin was substituted and kept in the regimen instead of ethambutol, that regimen was non-inferior to the standard 6-month regimen. However, I'll be honest, we thought it was going to be a lot better based on the phase 2 studies. And although it was non-inferior, it was slightly worse, about 1% worse, but non-inferior. When this regimen has been put into clinical practice, at least in some areas, and I know this anecdotally from discussions with the head of the TB control program in New York City, Dr. Joe Brzezinski, that the regimen has not been well tolerated by patients. And so I think this regimen, although we had enormously high hopes for it, is not having the kind of clinical impact at the moment that we had hoped. I think people can try it, but it needs a lot of close monitoring to help patients deal with adverse effects. And then finally, the last regimen is something that sort of comes out of truncate TB. I think truncate TB is a very complicated approach to treating TB, and I'll be interested to know what Jane thinks about this. I think we have so much experience and data with standard short course therapy for drug susceptible TB that I would stick with that.
Oh, thanks, Neil. So just some of my comments will be practical. And yes, I was going to reference your study of predictors for failure. So I was one of the people that would have picked the longer 9-month regimen for this fellow. The thing to remember that if you use the rifapentine moxifloxacin short course regimen, you have to ask for the fluoroquinolone susceptibility to be run. And that's actually is a delay in the United States that you might not know for a while. And this patient did have a treatment for pneumonia 4 weeks before he came into the hospital here. And if that was done with a fluoroquinolone, then you may have already lost that class of drugs. Outside of the United States, our high burden, low and low middle income countries have the accessibility of a gene expert cartridge for fluoroquinolone susceptibility, but that is not FDA approved or in any use in the United States. So you aren't going to know your fluoroquinolone susceptibility for a while. So I think from my conversations with Joe and the New York Bureau, that also is one of the delays, that patients are on the standard regimen for so long before they know the fluoroquinolone susceptibility that it doesn't make any sense to change.
Yeah, I think that's a great and very important point.
So Ryan's going to be actually discussing some of these studies for everyone to sort of understand and learn.
So we'll get to it. So this patient did get started on therapy. Just to go over the guidelines. So our ATS, our Society, IDSA, and the CDC all put out a joint guideline back in 2016. So at this point, it's before many of these newer trials were published. But in those guidelines, just to go over, they do recommend rifampin, INH, pyrazinamide, ethambutol, and they recommend that for an intensive phase of about 2 months, followed by 4 months of INH and rifampin for a 6 months treatment total. They recommend a daily regimen. They do discuss other regimens that are more intermittent, but they do point out that the daily regimens are more effective and are therefore preferred. Particularly if you're talking about patients with HIV and cavitary disease, more intermittent dosing is something should be used extremely cautiously because it's probably much less effective. In terms of other important points they make, they do suggest directly observed therapy over self-administered therapy. They do recommend the rifampin daily therapy, as I mentioned, over intermittent for intensive and continuation phases. And they do mention that they have an expert opinion to extend treatment to 9 months of cavitation and positive sputum cultures after 2 months of therapy, along with other considerations, for example, extensive disease. In terms of risk factors for treatment failure, we've already mentioned them, but extensive disease, cavitary disease, delayed sputum culture conversion, positive sputum cultures after 2 months are all risk factors for treatment failure, and HIV not receiving antiretroviral therapy. So there's been a lot of interest in getting shorter regimens for multiple reasons. Having a shorter regimen might improve patient compliance. It also be less of a burden because patients are on medication for less time and will have to take less medication. So there's been a lot of focus in the last few years since those guidelines came out about trying to do things that can shorten our regimens. One thing that's been investigated in some studies are potentially increasing rifampin dosing in order to shorten the regimen. And some of the thought process behind that is that it has been shown to potentially make cultures come negative faster, which is why it might be able to help out with shorter regimens. So to bring up a study, RIFA-SHORT came out last year, and this was a phase 3 randomized open-label international non-inferiority trial that examined higher doses of rifampin within the context of our standard regimen, just that the rifampin dose was higher. This particular study looked at drug-sensitive TB. HIV was excluded. It did have a really high percentage of people who had cavitation, 87%, and had 33% with grade 3 plus sputum smears, meaning these people had fairly extensive disease. They looked at 3 regimens. Essentially, the control was our standard therapy, and then for 2 arms, one, they replaced the therapy. They took the rifampin part, put it at 1,200 milligrams, so higher, and then even higher than that at 1,800 milligrams. Unfortunately, non-inferiority was not met for this trial. In their kind of own study design, they first looked at the 1,800 milligram arm and compared that to control, and then they didn't fully analyze the next arm if the 1,800 milligram was not found to be non-inferior, which was the case. Just to point out, it's actually interesting when you look at the actual data, not only is it non-inferior, it seems like the other regimens may have done worse. The control, 7% had an unfavorable outcome versus 10.2 and 13.4% in the higher rifampin dosing regimens. Just to point out a few other things about their data, a larger portion of people who were on the higher rifampin 800 milligram dose did end up having to change their treatment because of adverse outcomes. And an interesting thing to point out is that after 8 weeks of randomization, even though ultimately it was found to be non-inferior, the study regimens both seem to have had a slightly higher amount of people who had culture conversion after 8 weeks. That being said, 12 weeks after randomization, they all had fairly high rates of conversion. The next kind of step in figuring out whether or not we can do a shorter regimen is looking at some of these older drugs that we've known about for a while. Can they help make new regimens? So rifampicin, as we already mentioned, is essentially a cousin of rifampin with a longer half-life and might be more effective, and therefore might potentially shorten regimens. Moxifloxacin, a fluoroquinolone, which has activity against tuberculosis, has been shown in the past to accelerate sputum culture conversion. So there's been a lot of interest in these drugs. So as we mentioned, there's a seminal study that came out in 2021, the S31A5349 study by Dorman et al. And this was a massive open-label phase 3 multinational randomized controlled non-inferiority trial, which looked at over 2,200 patients with drug-sensitive TB that were ultimately analyzed, and 72% had cavitary disease, so widely applicable to our patient. They looked essentially at 3 study arms. They had our control, our standard Reich therapy, 8 weeks of rifampicin, isoniazid, pyrazinamide, ethambutol, and then 9 weeks of rifampicin and isoniazid. So 4 months total. And then another regimen that was rifampicin, isoniazid, pyrazinamide, and moxifloxacin. Their endpoint was TB-free survival after 12 months. And in terms of the results, rifampicin, moxifloxacin was found to be non-inferior. And actually, they had the time to stable conversion of sputum cultures was shorter in the 4-month regimen, so potentially showing some promise. They looked at the results and did multiple analyses, the intention to treat analysis. They looked at people who they made sure they had adequate microbiological data on, anyone who they looked at another kind of subgroup of an accessible population that had complete full follow-up. And no matter what they did for the rifampicin moxifloxacin arm, they found non-inferiority. For the rifampicin alone, without the moxifloxacin, that arm did not have non-inferiority. But we at least found one new regimen that's potentially shorter that we can use with patients through this trial. And a study came out last year that was essentially a subgroup analysis of patients with HIV in HIV who were within this trial and who had CD4 greater than 100, and they also found that the results were valid in that population, and non-inferiority was again demonstrated.
Ryan, can I make a comment about that study?
Absolutely.
Because I think it illustrates something that we need to bear in mind. When we planned that study, we planned it on the basis of 2 phase 2 trials that we had done. And the second of those phase 2 trials was a 2-month treatment, just the induction phase of treatment where rifampicin was used at a dose of 1,200 milligrams a day, as it was in the phase 3 trial. And in that phase 2 trial, at the end of 2 months, every single patient had become culture negative on solid medium. And at that time, that was the first time that had ever been accomplished in a TB trial where every patient was sterilized in 2 months. We thought that the phase 3 trial was going to be the home run of all home runs. And so the lesson here is that you can't extrapolate from a phase 2 trial to what's going to happen when you actually do the phase 3 trial and look at definitive endpoints. And I think people need to keep that in mind. We thought this was going to be the greatest thing ever. And although we demonstrated non-inferiority, I think speaking for maybe most, if not all of the investigators, we were somewhat disappointed in the results of the phase 3 trial.
Can I ask one follow-up question of you, Neil?
Yeah.
So isn't it that sputum culture conversion depends upon early bactericidal activity? And I always just remember the Mitchison's old slide showing the EBA of each of the individual drugs in RIPE regimen, but that actually when you put them all together, their EBA activity went down. And so is some of this the fact that when the drugs are in combination, their individual activity may change? I've never had anybody be able to explain that to me, so that's why
I'm not sure I'm going to be able to either. I think EBA turns out to be a very confusing thing, actually, especially when you look at EBA drug regimens instead of EBA. As you know, bedaquiline has almost no EBA in the first 14 days, but is a really potent drug. To me, what I took away from that, it just really points out that we don't have good surrogate markers of the effectiveness of TB regimens. And all we really have at this point is what we've had for 70 years is relapse rates. We need better biomarkers and surrogate endpoints.
Thank you.
Thank you very much. Interesting things to think about with the trial for sure. Just to kind of go, even with that, the CDC actually changed their guide, put out a new guideline in 2022 based off it. They did make a recommendation for this treatment regimen as an option. They did put some caveats in their recommendation: body weight less than 40, most types of extrapulmonary TB. It was not recommended for, and pregnancy and HIV not taking efavirenz therapy. The idea behind that is that efavirenz could interfere with some of these drugs. WHO followed suit. That being said, they also made their recommendations conditional due to a few concerns. They point out the higher cost due to rifampicin, it's a higher pill burden, and as you mentioned, you need to have fluoroquinolone sensitive testing, which may not be available everywhere. The next part of shorting regimen was potentially newer drugs. So bedaquiline is a dialquinolone. It targets APT synthase, and it's been approved by the FDA in 2012 for MDR-TB. Protominid is another novel drug from the nitroimidazole class. It can disrupt cell synthesis and doesn't have a lot of cross-resistance with other common anti-TB drugs. So this was approved for XDR-TB in 2020, and there has been some trials looking at whether or not these newer drugs that have been approved for resistant TB might be helpful in sensitive TB. So Truncate TB came out in 2023, which we've already briefly touched on, but just to go over that trial, that essentially looked at 5 drug regimens versus standard RIFE therapy. And it was a very interesting trial design, but they basically looked at some 5 drug regimens that all had isoniazid, pyrazinamide, ethambutol, and combined it with 2 other experimental drugs. The 4 arms were rifampicin linezolid, bedaquiline linezolid, high-dose rifampicin clofazimine, ropintin linezolid. And they actually looked at 674 patients with drug-sensitive TB, 54% who had cavitary disease. It will be noted, I did note that they did not include HIV, or people with 4+ smears, and people with 3+ smears were only allowed in the trial. It was initially an exclusion that was later removed. And their endpoint was a composite endpoint of death, ongoing treatment, or active disease. And they actually found that bedaquiline linezolid was non-inferior. It was 5.8% versus 3.9% in the control arm. Part of the trial design is that if people did not respond to the 8-week regimen, they could extend it up to 12 weeks. And the mean treatment time for the bedaquiline linezolid group was 85 days versus 180 days control. So even though this is not yet in any guidelines, and it might need some more kind of investigation and thought, it is potentially an option down the line. Another trial that came out this year is a SimpliCTB trial by Cevic. And this is another multinational open-label trial. There's a phase 2C trial. It was partially randomized. It was a very interesting design, but the idea behind it is that they enrolled people who are both drug-sensitive and drug-resistant TB. People who are drug-sensitive were randomized, so that was the partially randomized portion. And they randomized them to standard RIFE therapy versus an experimental regimen of bedaquiline, protominid, moxifloxacin, and pyrazinamide. And this was for drug-sensitive TB. The people with drug-resistant TB got a 6-month regimen of the bedaquiline, protominid, moxifloxacin, pyrazinamide. They randomized 303 people total. And what they actually found was that the BP-AMZ regimen in the drug-sensitive TB patients non-inferiority was not met. Their goal was to look for people who had a favorable outcome, and unfortunately, they didn't find non-inferiority there. That being said, in their per-protocol analysis, when they which was excluding people who had to discontinue the drug regimen for adverse events, they did find non-inferiority. They mostly attributed this difference to people who had to discontinue the drug due to hepatotoxicity. 11% people had to discontinue the regimen in the experimental arm. And there have been trials looking for protominid before that include phase 2 trials, and there have been some safety concerns in the past about hepatotoxicity. So while this is not yet quite there, maybe down the line, if some of these safety concerns can be allayed, this might be an option at some point in the future. I do want to note that the drug-sensitive TB, the drug-resistant TB people, 95% of conversion to negative culture by week 12. And for even the people with drug-sensitive TB, conversion did happen faster in this trial. So there is some hope here, even if non-inferiority was not met for their primary endpoint.
Yeah, can I make a comment about this as well? Because the B-Palm regimen, either the Xenix or the B-Palm regimen for the treatment of drug-resistant TB has really been almost miraculous, I think, for the treatment of drug-resistant TB, shortened from essentially 18 to 24 months to 6 months, excellent cure rates, and a lot of work has been done to minimize toxicity, particularly from linezolid. There's a lot of concern about emerging drug resistance to bedaquiline. And I think that alone is why we should reserve bedaquiline for the treatment of drug-resistant TB. So even, it won't be surprising if those regimens work to treat drug-susceptible TB. But my guess is we should still reserve that because it is the best thing we have for drug-resistant TB, and we should reserve it there so as not to lose it for those patients. I don't know, Jane, what do you think?
No, I would agree with you, Neil. And I think, the search for the Holy Grail in TB control is the shorter regimens. But tolerability, patient preference, I think that we need to be much more thoughtful about rolling out some of these. So I agree. I keep this in my pocket for drug-resistant TB or drug-intolerant TB that looks like an MDR TB because of drug intolerance.
That's actually a good segue to our next question.
Oh.
So speaking of MDR TB, so which of the following interventions would you recommend if the patient continues to have weight loss, productive cough, and fevers after 30 days of RIPE therapy? Would you continue RIPE therapy, increase rifampin to 1,800 milligrams, switch to an alternate regimen for drug-sensitive TB, or given that he's from Sudan, switch to a regimen for MDR TB despite the gene expert indicating rifampin sensitivity?
Let's take a look at the results of the poll, Tiana. So 44%, so there's sort of like a split. 44% said that they would continue the current RIPE therapy, and 44% said that they would switch to a different regimen despite gene indicating rifampin sensitivity. So Dr. Schluger, Dr. Carter, what are your thoughts about the voting, and what would you do?
I'll be happy to jump in first this time, Neil. I have a differential that I go through when people look like they aren't improving. With his amount of extensive disease, frankly, I would not be that surprised that he hadn't ended his cough and that he was still having fevers. The one thing that bothers me in this scenario is weight loss. But at this point, I always go through my usual differential. And the first one is always, is he getting his drugs? And to check about the issues of compliance. Then I would begin thinking about, is there anything else that's going on? And think about that differential diagnosis. Then I begin to think about drug malabsorption. The risks for drug malabsorption are usually patients with HIV, profound malnutrition, or diabetes. I'm not sure if he was quite thin, but I'm not sure if his malnutrition would be a problem there. But this is where you might begin to consider therapeutic drug monitoring. And I keep going, but I always stop and say, here's my differential. Do I need to be concerned about any of this? Over to you, Neil.
I agree 100% with all of that. I would add only that the chance that the gene expert was wrong about the rifampin sensitivity is very, very, very low. You're talking a 1 or 2% chance that was an error. So I still believe the patient has drug-susceptible TB, and 100% agree with Jane. The first question you got to ask yourself is the patient taking it? Is he getting it? I mean, this is a guy who has what we technically refer to as a lot of TB. And so Not the kind of person you expect to be afebrile and walking around, a week later.
Yeah.
I have a question.
TB is the disease, the infectious disease for doctors and patients.
Right.
Sorry.
Dr. Carter, you mentioned about therapeutic drug monitoring. For those of us who are not directly involved with the Department of Health and don't necessarily know about it, is this something that is available easily through the Department of Health for patients? And is that something that is used often?
I would say that it's not used that often. It is very interesting that the state guidelines for Virginia do routine therapeutic drug monitoring in all patients with TB and diabetes. But they are the only state in the United States that has a clear protocol that sort of checks off for every patient. It's therapeutic drug monitoring is only done at a few labs or levels in the United States. So it requires sending off, it's quite expensive. And so it's really done mostly on an as needed basis when you suspect that something wrong is going on in terms of absorption.
Thank you. Brian, do you want to move forward? In the interest of time, we have 11 minutes.
So
no pressure.
we thought possibly about switching the regimen, but fortunately, that's not what happened, actually. He did defervesce after 10 days of therapy. His first negative AFB smear was after 27 days of treatment. He had recurrent high-grade fevers after 28 days of treatment. So he initially had an afebrile period and then became febrile again, and he was reevaluated by our service after 14 days of persistent fevers. After we spoke to him, he endorsed improvement in cough and weight loss, despite the fevers. Some percent again, a viral panel was positive again for rhinovirus. He had a elevated ERCR and CRP. Otherwise, his workup was fairly negative. HIV was again negative. And he had a repeat CAT scan, and compared to his initial scan of diagnosis, it was read as thought to be somewhat worse with progression of his infiltrates. Which brings us to question 5. What would your next steps be for the working management of this patient? Would you do a bronchoscopy? Would you do empiric broad-spectrum antibiotics? Would you initiate prednisone at a dose of 1.5 milligrams per kilogram? Would you discontinue RIPE therapy and give an alternate regimen for MDR-TB?
Let's a few seconds and then we'll review the results. Take them up. All right, so 46% said that they would do a bronchoscopy with BAL. 31% said initiate prednisone, and 15% said they would begin an alternate regimen for MDR-TB. So Dr. Schluger, Dr. Carter, do you have any thoughts on this poll?
I'm definitely letting Jane go first then.
I think this is a little bit of a hard one. I usually don't use CAT scans for my follow-up.
That was going to be what I said.
So
I never would have ordered the CT.
I wouldn't have ordered a CAT scan. They're so sensitive, and we know that there's so much immunologic stuff going on in the lungs during the early phases of treatment. So I would have actually looked at other clinical issues about how he's doing. I always look at weight. I look at time to positive sputum culture, because that should be lengthening out if you're killing off the organisms. I look for other issues of what's going on. And I think Ryan is going to lead us into the issue of, is this a immune reaction as well, which I think would have to be considered, but I don't use CAT scans for my follow-up. Sorry.
Yeah, I'm glad you said that and went first, because I sort of agree. And to me, the most important clinical indicator or vital sign in a patient with TB is weight gain. Patients gaining weight, they're getting better. I might have just hung in there, but.
Yeah.
Brian, there's a question in the chat about why ANA testing was done specifically in this particular case?
Sorry, you cut out ANA testing?
Yeah, why was ANA testing done in this particular case? I can jump in if you want. I think the main reason was that we were just, I think may have been it was sent by the primary team, but I think there was just a question of like an inflammatory response. Was there another reason why this patient had a persistent fevers? And it was just part of the workup for persistent high-grade fevers for this patient. I don't think the suspicion was for a connective tissue disease or a rheumatological process.
And 100%, that's what the case was. It was just sort of everything being sent off as part of the fever workup, not because there was a particularly strong suspicion. So what we ultimately thought this gentleman had was TB iris. The reason behind it is because he otherwise was clinically doing better. He was actually hospitalized his full time, a lot of it due to social issues. So we had good monitoring and good sense of how he was doing. He was overall feeling better. He was improving. Otherwise, it was really just fever. So we thought this was an immunological reaction. We started on a course of prednisone, and immediately his fevers resolved and stayed resolved. The prednisone course was tapered over 4 weeks, and he was eventually discharged after a 2.5 months hospital stay. Again, a lot of that was due to social reasons, and for planned follow-up through the Department of Health for productive therapy. And the initial plan was for him to do 9 months total therapy when he left the hospital. So to go over what TB iris, which is what we thought this gentleman had, and which was the twist in our case, there are 2 forms that are described. There's a paper by the International Network for the Study of HIV Iris that came out in 2008 in resource-limited settings that sort of defines this. But they essentially describe 2 flavors. In patients who have TB with HIV who are started on antiretrovirals, you can either have a situation where they initially improve and then they have a subsequent worsening of TB symptoms within 3 months, and that's more of a paradoxical reaction, thought to be paradoxical TB iris. And then patients who don't have a TB diagnosis, antiretrovirals are started, and then subsequently they develop rapid progression of TB, and that's called unmasking TB iris, where we don't know about a TB diagnosis initially. In terms of the pathogenesis, it's not completely understood, but it's mostly in paradoxical TB iris thought to be an immune reaction, partially due to TB cellular antigens that remain even after treatment, exposure and release of new antigens with TB therapy, and immune restoration, which happens through a combination of TB-induced immune suppression, now that's being treated, as well as antiretrovirals in the context of HIV. Masking TB iris, there is still more data that needs to come out about the pathogenesis. It's not fully understood, but part of it is that CD4 cells are now being reconstituted after initiation of antiretroviral therapy for HIV, which in turn can help promote granulomatous response and restoration of the natural immune responses, following restoration of the immune system. This entity of TB iris is most commonly described in HIV patients. It can rarely occur in non-HIV patients, as in our patient. It's mostly documented in the case of immunosuppression regimens being withdrawn or solid organ transplant. It is rarely documented in an immunocompetent patient otherwise, like our patient. And it's more common in extrapulmonary TB. In terms of how to make our diagnosis, so the hallmarks of the symptoms are high fevers. You can have worsening respiratory symptoms, increase in lymphadenopathy, worsening infiltrates, and worsening findings on chest imaging was what our patient had. You can also develop abdominal abscesses, worsening liver function, as well as recurrent or new TB meningitis-like symptoms. The CRP is almost always elevated, as in our patients, and the median onset is 2 to 4 weeks. Again, similar to our patient, it almost lasts greater than 4 weeks. It's important to point out this is a diagnosis of exclusion, meaning that you have to make sure nothing else is going on. Just to bring up the incidence, how common is this? So there's a paper in 2015 by Namal et al. That kind of highlighted this for me, but they did a meta-analysis of 40 studies, combination of randomized controlled trials, observational studies, retrospective cohorts, and found a pool incidence of TB iris of 18%. But there was an extremely wide range amongst the study of what the true incidence is. Some went as low as 4%, some went as high as 54%, and there was significant regional variation. The majority of the studies they did look at, though, did pin the incidence somewhere between 11% and 30%. There are even fewer studies in patients who don't have HIV with who are thought to develop TB iris. It's thought to be 2% to 23%, but again, there is not strong data because there aren't as many studies. It is more frequent extrapulmonary TB. One study I did see of pulmonary TB specifically by Cheng was a single center cohort study in Taiwan, which found that there was an incidence of 2.4% of developing paradoxical TB iris in a non-HIV population with pulmonary TB. Pretty low overall. In terms of risk factors for developing TB iris, disseminated TB and extrapulmonary TB are thought to be risk factors: low CD4 counts, having a high HIV viral load, as well as a shorter interval from TB treatment to antiretroviral therapy initiation. It is important to point out that the guidelines do not recommend delayed initiation, even with this risk, except in the case of TB meningitis. Both genetics are all thought to potentially play a factor. Polymorphisms in IL-6, TNF-alpha, HLA genes, and natural killer NK receptor genes are linked to TB iris. In terms of the management, so for mild cases, supportive management is an option. Doing NSAIDs, if you develop effusions or ascites, doing thoracentesis or paracentesis is an option for symptomatic relief. There is some documentation of doing needle aspiration for cold abscesses that can develop in some cases. Steroids for more severe cases, which is what we ended up choosing in our patient. And for refractory cases, there is case report evidence for other immunosuppressions like TNF-alpha inhibitors, and thalidomide and montelukast.
And interrupt you for a second. For abscesses, I know it's sort of mentioned over here. I think typically we are very reluctant and hesitant to aspirate any lung abscess per se. Have you, Dr. Schluger, Dr. Carter, ever seen this being done, or is this something that is mostly in textbooks?
I've only seen needle aspiration for extrapulmonary TB abscesses in this instance. Neil?
Yeah, or in, you know, unusual cases where you have an actual TB empyema, but intraparenchymal lung abscess
There's always
really unusual.
There's always a concern for fistula formation, which is the other reason why I'm just always amazed at the fact that this is actually one of the recommended options. All right, Ryan, you can move forward.
Sounds great. So just to bring behind the evidence behind our management. So the evidence for steroids came from a 2010 trial, which was a single center, but it was a randomized, double-blind, placebo-controlled trial that occurred at a single center in South Africa that looked at drug-sensitive TB patients with HIV who were initially newly initiated on therapy, who developed paradoxical TB iris. What they did was, in anyone that they thought met the definition of paradoxical TB iris, they initiated prednisone at 1.5 milligrams per kilogram per day for 2 weeks, followed by 0.75 milligrams per kilogram per day for 2 weeks. And what they actually found was that it helped. Just to point out, they enrolled 110 patients. Not all of them necessarily were culture positive. Some of them were empirically treated, and some were noted to be smear positive for acid-fast bacilli. That being said, even with that caveat, they found that the median hospital days in the prednisone group was 0 compared to 3 for the placebo group. And they found that symptoms and radiographic findings improved more rapidly in the prednisone arm at 2 and 4 weeks. In terms of the overall prognosis, it's good. There's low mortality noted with TB iris. That being said, it's important to note with CNS TB iris, it's estimated as high as 30%. So that actually can be quite dangerous. And in addition, even though the mortality is low, there is a good amount of morbidity. A lot of patients, up to 24%, require hospitalization for their symptoms and for fevers. So that's something to note. This is not just, even though the mortality is low, this is not a benign entity. It is important to note that it does not ultimately impact TB outcomes. There was a retrospective study in 2020 by Narendran et al., which found that development of TB iris did not affect the frequency of unfavorable TB treatment outcomes. And they looked at essentially a retrospective study of a trial patient who had recently diagnosed with TB and HIV who'd happened to be enrolled in a clinical trial. The last thing I want to mention about TB iris is prevention. So there was a study that came out in 2018, the PREDART trial, which was the prophylactic prednisone to prevent TB iris. This was a phase 3 randomized double-blind single-center placebo-controlled trial. It enrolled 240 patients with HIV who were at high risk for TB iris because they had low CD4s, less than 100. And they tried prednisone 40 milligrams daily for 14 days, followed by 20 milligrams daily for 14 days. And they started within 48 hours of antiretroviral therapy initiation. And their endpoint essentially was seeing who developed TB iris. And they found that prophylactic prednisone did reduce the risk. They had a relative risk of 0.7 and 32.5% in the prednisone arm versus 46.7 in the placebo arm developed TB iris. People who did develop TB iris in their trial could be started on a higher dose of prednisone, but it seemed like prophylaxis did have an effect. Just to conclude our case and for our take-home points, the patient was eventually discharged, and 4 months later, he actually had to come back because he received a call from DOH to come to the hospital because of concerns about medication noncompliance. He reportedly only had taken his right therapy for 1 month following discharge. He was hospitalized for 2 more months to ensure that he took his medication, and he was discharged with stipulation that he continued directly their therapy. And as far as we know, has done well afterwards. In terms of our take-home points, expert opinion is to extend treatment to 9 months when RIPE is used for drug-sensitive TB in the presence of extensive cavitary disease with other considerations. The newer, shorter regimens for treatment of drug-sensitive TB are showing efficacy in recent clinical trials, including a 4-month rifampicin, isoniazid, pyrazinamide, moxifloxacin regimen recommended by the CDC and WHO, which we now know there are a lot of caveats, but there is some promise there. Novel anti-tuberculosis treatments do show some promise for shorter drug-sensitive TB regimen. TB iris has 2 described entities: paradoxical TB iris, which involves worsening of TB symptoms after initial initiation of anti-tuberculosis therapy, and unmasking of tuberculosis in patients with HIV initiated on antiretrovirals. TB iris can occur in non-HIV patients, but is uncommon and not as well described. Mortality is generally low in TB iris, although hospitalization is frequently required. And lastly, steroids are an effective treatment for TB iris and may play a role in prophylaxis in high-risk patients. And these are my references. Thank you very much.
That is a fantastic note to end on, Brian. Thank you so much, Dr. Schluger, Dr. Carter, for this wonderful session. I do want to thank the audience for their participation and making it an enjoyable learning experience for all of us. Thank you, Tiana, for helping us organize these sessions and seamlessly navigating through Zoom. I do want to make a plug for our next PINE session, which is scheduled on August 15th at 2 p.m. We will be discussing an exciting case of community-acquired pneumonia that is not responding to standard treatment. Hope you all can join us then too. Have a wonderful day. Thank you.
Thank you.